So thank you to be here and welcome for this new year. And I wish you a happy new year. And I want to thank all the partners of the project. I want to thank all the parents, association for their participation to the project. I want to thank the member of the Interreg program for their advice on financial support. So now we can start by the presentation of the motion project. I will do an overview of the different part of the project. So Motion is an European project co-funded by Interreg of 2C with two main objectives. First is to advance development, validation, and adoption of bionic rehabilitation technology for children with CP. And the other main objective is to set up a transregional network because we want to transfer the rehabilitation technology and knowledge from research to practical application. So we've got 40 partners, different 4 countries on a budget of more than 7 million euros. So all the partners are located in the different area of the Interreg of 2C, from United Kingdom, from Belgium, from Netherlands, from north of France, and from south of France, for somewhere. And we've got some observers of the project. The Motion project starts from an observation, which is the ongoing challenge of caregiving to children with multiple motor dysfunction, because it's one of the most important tasks in pediatric and child neurology and medical rehabilitation. We've got some clinical aspect of the project, measure the rate benefits risk of the different technology developed, and we have to measure the interaction between human machine and to have the feedback of the user. And in the second part, we can explore some fundamental aspects as motricity, cerebral plasticity, and so on. So we start from an actual state of play, which is a daily static verticalization. And we've got motorized verticalization, and we've got some complex system at hospital and very expensive system to assist work as Locomat. And we want to obtain 3 independent modules here with a garment to collect data and to have a feedback of the on the user geological measure. So this is for the technological challenge. For the human challenge, we've got we want to accelerate the adoption of bionic technology and by parents, professional, as well as general publics, because family must or could access appropriate technology to improve balance and well-being. So to do that, we need to assess the. Yes, go on, go on. Now we have to assess the training need of professionals and parents in biologic rehabilitation. We need to develop a network with all the European stakeholders, and we've got a map. And after that, we have to provide better care rehabilitation for children with neurological disorder, and we have to train some training module. So motion output is based on 4 motion is based on 4 inputs. The first one is about the different module of the exoskeleton. The second one is about the the garment. The third one about the pilot of the final exoskeleton garment, because we want to achieve a level 5 for the innovation. And the last output is about the feasibility study and transfer of the technology. To obtain the result of the different outputs, we have a co-creation action. It means it's a virtuous circle. That means we start from the needs. We develop something, for example, here modules, and we've got a backtracking loop between the developer, the clinician, and the user to improve the system. So we do that for all the different outputs. For the output 1, test and validation of the exoskeleton bionic rehabilitation technology, we develop a rehabilitation robot of the lower limb part, which is called an exoskeleton robot, and we choose movement control, and we have two different ways to do that. We've got passive control with passive working model. That's what's called the lower limb part, which is put here. And we've got active control with physical interaction, which this is the two modules for the PAFO and hip module, which are here. An interaction is, for example, the compensation of human gait. So the outcome of this output is 3 functional modules ready to be evaluated for TRL5 with the powered ankle foot orthosis and lower limb test on adults. We've got a replication of the lower limb by the UCA teams, and I think there's a running application of the PAFO system in UCA too. We have more than 30 product development companies involved, with 3 major companies, which are Dassault Marketplace, Maxo Motor, and MATLAB. And we've got some parent association and stakeholders involved in this project. And we have 4 papers published, 3 international congress and 2 reviews, 3 specialized magazines to promote the output, and participation to 4 seminars and congress, and we've got active communication networks. For example, we have more than 2,000 views of the lower limb part, for example, and we win the first prize on the video award on the 2C events. In the same way, for the output 2, this is currently develop a scalable garment to ensure measure acquisition with comfort for the children. So we've got the smart textile garment on the front-end application, and we want to acquire some different characteristics on the patient. So we've got a CG, heat flux meter, respiratory rate, and galvanic skin response. So we have to compare this sensor to existing medical device. And because we want to measure comfort and acceptability of the structure, we developed a stress algorithm for assessment of the usability of the exoskeleton during trials. The outcomes for this specific output 2 is a functional garment in 3 sizes. We've got the quantity and the size here. We've got, we reached 5 product development company, and 4 papers published in international congress, 1 submitted, and 3 specialized magazines, and 1 PhD presented next month. We've got participation to 3 seminar, congress, and webinar to promote the technology. The output 3, which is a pilot of final exoskeleton and garment prototype, and we have to prove that we achieve the TRL5 for the mechanical part and the garment. So TRL5 means that we have to perform some tests on CP children in laboratory environment. That is the most closest as the real future use of the system. To do that, we have to define some clinical protocol for each part. We have first to evaluate the technical module. And after that, we have to do some clinical evaluation for the different parts. So in a cumulative way, we have 50 children involved. The outcome of this output for the powered ankle foot orthosis, TRL 5 is reached. Okay. We define 4 protocols, 20 children, 5 volunteer adults involved, one test training on children, and 2 modules with TRL5, which are the lower limb part and the PAFO. For the garment, we will reach it very quickly, and for the hip modules too. You can see these different modules during the demonstration at 12. So to exchange use and practice, we have a clinical protocol, a guideline paper, test training with 3 CP children. For the hip module, we have to test it on volunteer adult, and for the lower limb part, all the documentation is ready, and we've got some movie with different testing done on adults. And for the garment, we've got original protocol with virtual reality for stress detection. We have an ethical approval is pending in UK to make a test of the garment. So that's for the output 3. And for the last output, which is feasibility study and transfer of technology. So to do that, we have to define a long-term strategic plan, which need to have a roadmap for relevant stakeholder and to create a network to facilitate the transfer to the technology. We need training units and train the trainer evaluation to be sure that we are reaching the good target and the need of the markets. And after that, we have to test the different technology during a pilot test to assess the efficiency of the technology we developed during the different tests. So the outcome of this particular output is about the state of play of the bionic technology. We've got the survey study, which has been realized by the partner from CCE. This study gives us the different indication about what we have to do with our technological system. First, on what are the needs of the practitioner, the user. For example, on how they perceive this kind of system. And you can see here that the perception is good, okay, for example, for improved self-esteem and quality of life, which is an important part of the project, improve the quality of life. But in the same way, in the same time, we need more information on training because only 7% responder use this kind of system actually. So it's important to develop this part of the training system. We develop new form of cooperation because we can assume that interactive dashboard we've got on the database allows this cooperation as partnerships. We make 3 stories on the website of 3 major companies with more than 2,000 views. For example, we've got so we've got in the database more than 300 contacts, and we've got more than 200 volunteer responders to the different survey. And for example, for improved service, we've got the train the trainer module, and we've got, for example, different indication of what we have to include in the training model on the satisfaction of the different participants to the evaluation. Next outcome is about the pilot study on and 23 children with CPs, and so on. So we've got some preliminary result of the set of normative clinical gait analysis with a variability in peak flexion of knee for child with CP relatively higher than for the other one. So it's maybe a future indicator to have in mind. From the for the stress identification, we find that two features from ECG define a model with a good accuracy. For the power system, the gait event detection system is considered as very accurate and could be extended to other modules and is used for the hip model, for example. And for the lower limb part, we see that there's a necessity of multiple sessions before controlling the system for adults only. On the different tests, we have no pain and muscular problem with adults. So that's the outcome of this output 4. So we have to share the knowledge and the technology. So we participated to different, we made some different action. So for which different target, for example, we have a lot of scientific publication for target which are the clinician and the engineer. We've got specialist press to disseminate, for example, in textile press or something like that, to disseminate the output. We've got public press to disseminate through a large public the different part of the system and to speak about the bionic rehabilitation system, and we participate to some demonstration on fair to show the system in action. So you can see some photos of the different participation. We reach a lot of contact in physical and rehabilitation therapists. It's the most reached target. We've got product development, which are very high too, and parent and association, which is important too as a target. And we have a distribution between the different country and the different fiction. So that's for the stakeholder. And for the cross-border cooperation, we have a strong partnership based on trust and communication with common scientific publication and physical and online meeting together and all over the world, I think, as you can see here. Yeah, I think it was it was in Lille, in Lille too. So, and we do it because we don't know it wasn't impossible. So you can go join us on the different social networks if you want to have some information and to participate to the project. So merci. Thank you for your attention. I don't know if there's some question. In the room? There's a lot of questions. Ah non, il traduit directement ce que je dis. No, it's a transcription. Sorry. Okay, so no question via Teams. So I think I was very clear in my presentation. So now we can go for the first presentation. I think it's Eleni from ACCE. We will start the presentation. I give you the microphone. Yes. Ah non, c'était...
Do you want to do the witness? I was going to say it first, and then I can.
As you want.
Yeah.
You want to speak now? Yes.
All right.
So we change a little bit the program.
Program. Okay.
No, sure.
Yeah.
We will have the video of the witness after the presentation.
Okay. Just try. It's working, you think?
So you can.
Wait, where is the pointer then?
Here.
That one. Okay. Good morning, everyone. And my name is Eleni Hatzidimitriadou. I'm a professor at Canterbury Christchurch University. And I'm leading still the Christchurch team for the Motion project and collaborating with all the wonderful people in this partnership. So this morning, I'm going to talk about the assessment of training needs. This is what Lorraine showed you earlier in terms of what we did to try to prepare ourselves to develop the training for low limb exoskeleton and robotic assistive technologies. Just to say briefly, because some of my colleagues are online, some of my colleagues are in the room. So my team is Joanna Apps. So she was one of the key people who conducted the survey. And Dr. Maria Steins, so she will be talking later on, and Dr. Julia Moore. What we did was part of what we call fondly in our applications for the project as D321, which was the purpose of that was to do an assessment of training needs of healthcare professionals, because as Lorraine explained, we wanted to understand how healthcare professionals understand the technology, what kind of technology they have used, what are their training needs, so we can enable and facilitate the transition of the technology from the lab to the actual practice. And therefore, we set out to do an assessment of needs. We wanted to explore, as you can see here, the knowledge, experience, attitudes, and training needs. We wanted to do this with healthcare professionals, but also with parents of children with CP. And we wanted to this information, this survey, to inform the next steps of the training, the development of the training we conducted. In order to do this, because we were doing this during the COVID period, also we were doing this, in 4 countries. We had an online survey we designed on the basis of previous studies. So we based our survey on a previous Interreg project, the ADAPT project, where we conducted a similar survey for assistive technologies, but we also took on board literature reviews we did for the purpose of the training. And we designed this survey for healthcare professionals and also for parents. For parents, we wanted to do an interview, so we remained flexible, trying to engage with parents as well, face-to-face or by phone or video. But eventually, because it was technically difficult due to COVID, we had to do self-completed questionnaires. And as I said, it was 4 countries, so it was France, Belgium, Netherlands, and the UK. And if I showed you very, very quickly the content of the survey for both professionals and parents. So the first area for HCPs, you can see we were asking the region, the sector, the years of experience. So we're trying to understand where these people are working. That was important because it was interprofessional, multidisciplinary group. And we also wanted to understand their experiences and their knowledge. So we were asking them questions around the training they had, but the use, how they prescribed robotic assistive technologies, what kind of perceived understanding they have of their knowledge and the adequacy of the information they have, their ability to work, on this with these technologies. This was to do with attitudes, so it was towards attitudes, because we realized this is a very, very new technology, it's cutting edge. So we didn't have the opportunity to understand previously, and this is one of the unique surveys that has been conducted at European level, what kind of experiences or attitudes or training needs professionals had towards this technology. We wanted to do the same with the parents, but this time the focus was on the age, of the children that we're caring for, and the child's mobility or other aspects of, issues in terms of their disability, the therapy they received, and how this technology may have helped or could it help the children in the future. So it was very much, what you know so far and what you would like to see happening later. So in terms of professionals, Lorraine mentioned this. So we had a sample of 5 professionals responding. The majority of them, as we were expecting, were physiotherapists. There is an additional sample of 89 professionals in the UK who we continued that survey. And when we publish the final reports, they will be added to the sample, but more or less it's the same findings. So you see that most people were working in community-based services, but also in hospitals. And you can see the breakdown of the different professional groups. Very, very few people, only 7% had any experience using lower limb robotic assistive technologies. But the majority of them wanted to know more about the technologies, and they wanted to know how to use those technologies. And it was quite confirmation of what we knew from the literature and from experience and working with colleagues, clinical colleagues in the project. So we also asked them about the purpose of using this technology. We want to understand, of the different uses. And between us as cross-border partnership, we had a lot of discussions with Dutch colleagues, with French colleagues, with Belgian colleagues. Is this technology, and of course UK colleagues, what is this technology for? So a significant number of them, half of them said it was for training to improve gait function. An equally high number was for assistive device for use of daily life for gait. So that's quite different because services that are based, community-based services like in the UK, this kind of devices could really enable quality of life, in the community. And also the training device to improve secondary health outcomes, because it's not just improving gait, but it's improving quality of life ultimately. And then in terms of perceived, purpose per country, you see we do have some differences here at the bottom, but all of us agree in the 4 countries that these priorities are more or less the same. But in some cases, like in the UK, France and perhaps Belgium, some of the, people thought more strongly about the secondary health outcomes. So it was to do with the systems, of care in the different countries. And then we asked them, as I said, about their confidence to use technology. And you can see here that people are not really confident to use it, or very fairly confident. But overall, HCPs, professionals were really not very confident using the technology at the moment. And again, the breakdown in the countries is quite interesting. But, in some cases, like in the UK, probably because of our training systems and how we support professionals on the ground, very few people thought they were confident, so the majority were really not very confident at all. But in other countries, we see a little bit better, but still a lot of gaps in their knowledge. The benefits for the technology, gait retraining, absolutely very strong, improved joint mobility, improved self-esteem and quality of life, and extended independent walking. So this was again expected from literature, but this was a confirmation from the professionals that these 4 areas are key priority areas for them. And barriers to the training, we wanted to understand if training is designed, which we did afterwards, how are they going to sort of use this training and what are their concerns, what are the barriers, for the training. And the majority of all of the countries, the majority of professionals said, we are concerned about the cost of the technology. Of course, we all know robotic technologies, assistive technologies are quite expensive at the moment. They also worried about the lack of funding for the training. So that's to do with how their services, the government, the local authorities supporting this training, and also ongoing support in the use of technology when they come to the clinical practice. So all of that was quite significant, and it was also similar partners, pattern apart from France here. There's a bit of, we need to do a little bit more explanation, but all 4 countries said the same thing. Interestingly, Lorraine talked about existing technology. So we did ask them, have you heard about this? Have you used this? What kind of technology? This is what they came up with. We didn't give them a list. So this is a long list of robotic devices, other devices people were thinking were robotic devices. That's interesting too, because professionals don't always know which devices are the robotic assistive, devices, but some of these names are known, but obviously this is again very new area. In terms of parents, we did have a smaller group of parents participating, but most parents had quite a lot of experience of children not walking. So more than half, actually had children who could not walk independently. They were significantly affected in other areas of their life. And the vast majority were receiving therapy, mostly physiotherapy. And they were actually quite frequently using therapy. So 2 times or more times per week. Now, we did ask the parents, have you heard about robotic assistive technology before? So that was surprisingly because a lot of parents knew about this type of technologies. And they heard, the term before, exoskeleton as well, which was one of the emphasis of the project. But again, no surprise, very few had any use or used it with their children before or had any experience using the device. So some of them were using robotic assistive technology, but not lower limb again. So it was interesting to see that. And we asked them about the training. This was different because professionals need more clinical training. In this case, with parents, we wanted to understand what kind of information they would need to use the technology more. They didn't have any concerns, in terms of using wearable technology. And that was interesting too, again, because there is a kind of myth in our sector that parents may be quite anxious about using the technology. In fact, they were quite welcoming and very positive. They wanted to know more and they wanted to actually understand how technology could help their children. And they said, again, an interesting fact that, quite high numbers said they would be confident using this technology with their children. So they were ready to sort of embrace this kind of technology. So finally, we used all of this to understand what kind of focus we should have in our training. So for professionals, we understood that they wanted a mix of online and in-person training. And that would be the best option, for the training. Some of the areas we needed to concentrate is suitability of wearable technology, contraindications of use, safety, fitting and customization to individual needs. So all of this is very practice-oriented, prescribing and funding. Of course, more basic stuff, how it works, what kind of, features, need to have this kind of technology. Interestingly, legislation, policy around technology, so they can understand, the kind of things they could do as professionals. And then for the parents, it was very much, they wanted to have in-person and mixed kind of interactions with individual and group kind of training, and online much less than the professionals. So they wanted to see this more face-to-face. And in terms of benefits, they wanted to see to understand the benefits of the lower limb robotic assistive technology, practicalities, how they could use that kind of technology, and also the effectiveness of the use, because they need to be convinced, as parents, how this is going to help my child and where they could get some ongoing training and support. So thank you so much for bearing with me. So the next part of our presentation is going to be my colleague Maria Stein explaining what happened next. Thank you.
Hello, can you hear me? Okay. I'm Maria Stein. I am on the Canterbury Christchurch University team with Eleni. My background is in occupational therapy, and I am actually a clinical academic. So I'm going to talk a little bit about the development of the training program today for Motion. So there were several aims of this training program. Of course, it is one of the outputs for WP 3.2.4 activity. But the main aim was to bridge the gap between the theory, research, and professional practice. This gap, as you heard Eleni speak about, was identified in the surveys and also in the literature, including some reviews that the team actually conducted. Another aim was to support healthcare professionals and families and carers in understanding about lower limb robotic assistive technology and its uses with children who have neuro disabilities. So there are 3 units in this program. Unit 1 is mostly theoretical. Unit 2 is more applied, and Unit 3 is a train the trainer. As you see here, each unit has elements of the following content. So it's been informed by findings from surveys and literature reviews. Some of them also were actually published by the team here. It's also been informed by multidisciplinary professional expertise from both UK and partners, and also with consultation from members of the advisory board. So we had to have a model to underpin the development of this training, and we selected the biopsychosocial model of disability, which was adopted by the WHO in 2001 and embedded in their international classification of functioning framework that you see here. So why this model? Because it is really quite a comprehensive model. It does acknowledge that personal factors, biological, psychological, and social factors that you see here actually interact dynamically with the environment to produce health or disability. It emphasizes health rather than focusing on disability, which was consistent development of this training, and we wanted to try and use more positive language rather than negative language when it comes to disability. So how did we develop the units? We invited quite a lot of organizations internally and externally to send content to us that was relevant. Then, once we had enough content, we sorted this out according to relevance, clarity, and appropriateness. And then we synthesized the content into a more coherent form, given sections and an outline that we had already predetermined we were going to use for these units. Once we were happy with the draft, we circulated this to the e-learning technician, and he set it all up on our e-learning platform, which is Moodle for this project. And once this was done, we sent it out to internal and external reviewers for additional comments, and in order to be able to refine the actual content. Once we were happy with this, then we finalized it and published the units. And up till now, we have published, really. We have out there both units. So something about the features included in each unit. So there are optional voiceover. There's also images, graphics, and quite a few videos, and some of these are optional, and we have indicated these where possible. There's also quite a lot of links to outside resources and important information. Again, there's optional and recommended viewing and reading. We have a number of self-reflection exercises to punctuate the text and the fact that people are always looking at the screen because it's online. So it's good to do some reflection and actually understand more what's being learned as part of that process. And it also deepens the learning as well. Unit 2 has a case study, and this comes with a model answer guide so that the learner can actually compare their answer with the guide that we've given. There is a quiz in each unit, and once this is completed successfully, one can actually print out a certificate of completion that they can put in their records or, for example, in their CPD portfolios, continued professional development portfolios. Then there is an evaluation for each unit, and this is available in 3 languages, English, French, and Dutch. So I'm just going to give you a little bit of time to look at this. So this is a finer breakdown of what is actually in Unit 1 and Unit 2. So if you can have a quick read. And for Unit 3, Train the Trainer, this consists of a series of presentations and webinars mostly, covering key issues in the use of robotic assistive technology in rehabilitation. It also highlights some global differences in education, training, and approach to robotic assistive technology, and actually concludes with the presentation of the motion technologies. So I've got a demo now of Unit 1 and Unit 2, and this should give you a flavor of what to expect. How does this look actually on the screen? So hopefully this will play. Do we just press play? Oh, okay. Volume's up. Oh. So what do we do now? We just leave it. Well, you can have a look, but there's no sound. It's a silent. I think it's probably self-explanatory, but at least have a look. Okay, and here comes Unit 2 without the background music. They wear headphones, so they do hear, so you
So that's why we couldn't show everything, but this is.
But they don't have to have the sound, so they can choose not to have the voiceover. Okay. Okay, so we ask the learners to complete an evaluation after each unit. And this is based on the first two levels that you see here, level 1 and level 2, reaction and learning of the Kirkpatrick model. These look at ways of measuring people's responses and also whether they've increased their knowledge, skills and experience as a result of the training. Of course, this is important for us because we use this as evidence of the value and use of what we are doing. So now I've got some data about the training. And as you can see here, up till the 10th of January, we had 100 registrations across all 4 countries, which I suppose is not bad considering that we've only really published this end of November and Unit 2 beginning of December. And then there was Christmas and New Year. So people had a break. For Unit 1, we have 15 that completed the training and we've got 12 evaluations. For Unit 2, we have 4 so far and we've got 1 evaluation. And for Unit 3, we in the UK have delivered a webinar to a rather big group of physiotherapists, which went very well, and a presentation to the Northeast NHS Trust, and between them they had just over 100 attendees, and we've got 16 evaluations from the webinar. So I cannot present all the questions in the evaluation survey, but I've selected a few that I thought might be interesting and you want to know about. So one of the questions that we asked for the evaluation, and this is particularly from Unit 1, is, was the content clearly presented and interesting? And as you can see here in the first chart, most 11 out of 12 agreed or strongly agreed that actually the content was both clearly presented and interesting. Another question that we asked in the second chart was, how easy was it to follow the content? And 11 out of 12 agreed or strongly agreed that this was actually fairly easy to follow and negotiate. This question asked about how engaging and professionally relevant they thought the content was. And as you can see here, 9 out of 12 actually agreed or strongly agreed that the content of the units was both engaging and professionally relevant. We don't have a lot of evaluations, but this is based on the evaluations that we have so far. There was another question where we asked for 3 important learnings that people have taken out of the units. And as you can see, this was quite a varied response. People have learned really quite different things, quite a lot. But for me, the most interesting ones, these ones down here. So the reasons why we should be using more robotic assistive technology, particularly alongside traditional therapies. Different technologies that are being developed or out there already. And the considerations, obviously, that we need to be thinking about before using these technologies. And how do we scale these from adults to children requirements. So this is a chart from the webinar that we gave. And there were 16 evaluations from this one. And this asked the attendees to rate the webinar content and delivery. And we have 15 out of 16 that indicated that they were likely to use what they've learned in practice. It's good to know, really, that people think they can make good use of this. So the training is out there and it will be available online and free till the end of March 23. We would welcome a lot more people to engage with this training and also obviously more evaluations to keep refining the content as well. And in the hope that it would be really useful in the future, even maybe after the life of the project. So if you can help us disseminate this training, there is the details there, and we would like to hear from you to be able to enroll more people onto the training. So I hope you know a little bit more about the training, and if you have any questions, I'll try and answer. After March, you mean? That is a question I don't know. Anybody can answer?
So our university is going to maintain the training open for I hope 1 year at least, and then we want to embed the training in our programs. At the moment, our students are undertaking the training. So we are discussing with colleagues, especially in the UK, to sort of undertake, and if other universities are interested, schools, and we're very happy to discuss, directly, because we want to create a kind of alliance, for the training, make sure we keep it, open for whoever wants to use it. I mean, the feedback from our students so far is fantastic. So I hope we will be able to use it, to educate professionals and to be professionals, future professionals. That would be great.
Yeah, I think perhaps the challenge is more to keep it up to date after the March 2023, because there's some stuff in there that needs to be updated as we go along, and more development and more design and what have you. Yeah. And it's a shame because this is really quite a lot of work. So it'd be nice to see this work being promoted.
The training board from the partners, from the partnership and other interested parties, and to continue monitoring the training and disseminating the training beyond the project. So I'm very happy if colleagues from the university are interested in.
Any more questions? Done? Thank you.
So maybe we can come back. There's really no problem with the sound. So we'll have some different movie about different witness, parents, children, and professionals. So from the different country. So we've got first movie about motion. No, celui-là. Celui-là. 7, 4. So, first of all, we have the point of view of a parent, which is present in this room. This is Luc Masson at the genesis of this project. So thank you, Luc. For your participation. Maybe I can show you the movie. There's no sound. I don't know. But I don't know why there's no sound, but it's in French. Il faut changer le micro. Le micro.
Ma fille, et pour tous les enfants comme
Merci.
Et par extension, toutes les personnes. Bonjour, je m'appelle Luc Masson, je suis le père d'Inès, aujourd'hui une adolescente adulte même de 18 ans, polyhandicapée. Il y a 12 ans, j'entre en contact avec Laurent Perrotti, Julien, pour lui proposer de développer un exosquelette de marche, au départ évidemment pour ma fille, mais pour tous les enfants comme Inès, polyhandicapés. Et par extension, toutes les personnes neurolésées ne pouvant pas se déplacer seules. L'idée de créer une structure autonome qui pourrait se déplacer sans l'action ni d'une tierce personne, ni de la personne handicapée elle-même. Inès est donc polyhandicapée. Elle ne voit pas, elle ne parle pas, elle ne tient pas du tout, elle ne marche pas, elle ne tient pas assise. Et donc, pour être verticalisée, elle a besoin d'une structure extérieure. Jusqu'à présent, les centres dans lesquels Inès est accueillie utilisaient des structures en résine dure, avec un revêtement en mousse. Et donc, il y a 12 ans, je me suis dit, pourquoi pas essayer de la faire marcher, de lui permettre de faire quelques pas, ne serait-ce que pour avoir la sensation de la verticalité, et pourquoi pas participer à sa rééducation. En 12 ans, Laurent Perrotti, ses étudiants, les équipes qui ont travaillé sur la première phase du projet, ont développé un démonstrateur avec l'association Gelou, dont j'étais le président à l'époque. Nous avons levé les 450 000 premiers euros qui ont permis de développer ce démonstrateur, qui a ensuite servi d'explication sur la finalité de ce projet et qui a permis à Laurent Perrotti et toutes les personnes que je voudrais remercier aujourd'hui, avec lesquelles il travaille en France ainsi que dans les pays partenaires, qui ont permis donc de lever les fonds Interreg2Six qui permettent le développement actuel de Motion, donc notre prototype d'exosquelette. Je sais que nous sommes dans les dernières phases de développement technique. Je sais qu'il a été compliqué pour toutes les équipes pendant cette période de Covid de travailler ensemble, même si les nouvelles technologies de la communication facilitent quand même le co-développement à distance. Mais je tiens à remercier évidemment toutes les personnes impliquées dans ce projet et toutes les structures hospitalières, de recherche, universitaires, entreprises qui, partiellement, ont travaillé à la globalité de ce projet. Je souhaite, moi, pour Motion, aujourd'hui je pense qu'on appelle le projet INES, c'est qu'on puisse passer à une phase de fabrication, qu'il puisse y avoir à l'avenir 1, 2, 3 exemplaires de Motion dans des centres de structures accueillant des personnes polyhandicapées neurolésées, afin qu'elles puissent bénéficier de cette orthèse autonome et qu'elles puissent faire chacune de leur côté, soit en France ou dans un des pays partenaires du projet, leur premier pas, découvrir le monde posé sur leurs deux jambes et non plus uniquement au fond de leur fauteuil roulant ou voire éventuellement au fond de leur vie. Donc je réitère pour la 3e fois mes remerciements à l'ensemble des membres des différentes équipes européennes qui ont travaillé sur le projet. J'espère pouvoir vous rencontrer un jour. Ce ne sera pas possible puisque l'INES actuellement n'est pas en état d'être déplacé. Je vous envoie quelques photos retraçant, je dirais, le parcours d'INES depuis ces 6 ans jusqu'à aujourd'hui, et pour vous montrer également l'utilité de cette structure autonome pour elle, ainsi que pour toutes les personnes qui pourront en bénéficier. Merci à tout le monde et au revoir.
Okay, and now that you've seen the technology, what do you think about it?
I think it is very groundbreaking and it will help a lot of people like me be more independent, have more freedom and be less dependent on things like wheelchairs or cables or canes. It will help you walk faster and be able to pick up people and maybe do things faster as well.
I think it looks really exciting as a parent of a child with cerebral palsy who falls over a lot of times. I think it will give more stability to their walking, perhaps hopefully correct their gait, because their feet might roll in or they may just go on tiptoe or their heels, so it'll actually help them to keep their feet flat on the ground. I think also like the tiredness that they have because of the amount of walking and how their muscles get tired. So hopefully having that extra support and the motor in that will help them be less tired at the end of the day, or however long they use it for, just stop that tiredness and their muscles from tightening up necessarily. So yeah, it looks brilliant. It looks great. Get technology.
Pathways give children with cerebral palsy an experience of a more typical gait pattern, which they are unlikely to have experienced before. This would be particularly so following orthopedic surgery to the lower limb. It can also provide opportunity for muscle strengthening of the weaker muscles around the ankle and lower leg through repetitive movement, as they are not necessarily able to use their full range without assistance due to their weakness. PAFOs have the potential to promote normal ankle locker function, and this, in turn, should increase the extension potential, enabling the child to mobilise with a gait pattern that is more biomechanically advantageous.
It's the first movie. I don't know if you have some reaction.
You should have loved me more.
In the movie match was present. So I have 2 other movies, one from Netherlands and one from Belgium. So Netherlands first. From St. Martin Clinics.
En wij zijn een van de partners van het project. Vandaag heb ik
Ik ben Esther van Lommel. Ik ben werkzaam op de Maaskliniek, kinderrevalidatie en Ik heb de afgelopen jaren veel werkervaring op kunnen doen met kinderen met CP, cerebrale parese, kinderen met spierlividaat, met spierziekten, maar ook met syndromen en ernstige eenvoudige beperkingen.
Welke problemen hebben kinderen met CP in het dagelijks leven?
Kinderen met CP hebben onder andere moeite met aansturen van beweging. Ze worden vaak belemmerd door spasticiteit, spieren die te kort zijn, sturen die er zijn. Waardoor ze eigenlijk negatieve gevolgen hebben tijdens het lopen. Dus dat ze snel uit balans raken, vallen, struikelen en het niet nog iets voor kunnen doen.
En heb jij ook ervaring met verbodensteuning?
Nou, ik doe veel postoperatieve trajecten bij kinderen met CP. Die geopereerd zijn uit 1 of 2 benen, maar dan op meerdere niveaus, dus op 4 en op 1 niveau. En daarbij gebruik ik inderdaad verschillende technologieën als chirurgie, bril en stereo. Hierbij maken we in de eerste fase van interventie gebruik van de chirurgie, waarin het gewicht ondersteund wordt tijdens staan en lopen. Zo kan de nieuwe manier van lopen worden getraind, waarbij het kind manueel ondersteund en uitgelopen wordt voor bewegen. Ik behandel ook kinderen op de Creo en de Simeo. En dit zijn loopbanden met een virtual reality systeem, waarbij kinderen uitgedaagd kunnen worden in het handhaven van hun balans tijdens het staan en lopen. Ze dragen daarbij een veiligheidsharnas, zodat ze kunnen worden opgevangen als ze vallen.
En heb je ervaring met het exoskelet?
Ik ken het exoskelet bij
Ja,
revalidatie. Laat gebruikt wordt bij patiënten met verleden dwarslesie. Ik heb zelf geen ervaring met het exoskelet als fysiotherapie. Ik denk wel dat een exoskelet gebruikt kan worden om beweging te ondersteunen vanuit de knieheup en enkel. Of dat het deels ondersteunend wordt, dus voor een knie of voor een heup of voor een enkel. En ik denk dat dat vooral tijdens looptraining belangrijk is om toe te passen. En voor dagelijks leven is het nog eigenlijk wat groot en dom om niet in te zetten. Dus ik denk dat het kinderen niet is.
Zou het exoskelet kunnen helpen om de kwaliteit van leven?
Wanneer een exoskelet een beweging een deel kan ondersteunen, dan zou het zeker helpend kunnen zijn. Uiteindelijk wil je dat het kind die beweging gaat toepassen bij de mensen mee leeft in het dagelijks functioneren. En hoeveel training dat nodig heeft om dat te bewerkstelligen, dat is nog lastig in te schatten. Dus daar kan ik eigenlijk tegen uitgaan.
Maar wat vind je nou eigenlijk van het Motion project?
Ik denk dat het een mooie ontwikkeling is om te onderzoeken hoe technologie kan bijdragen aan het welbevinden van kinderen en de ouders en de kwaliteit van leven dat zij ervaren. Dus ik denk dat dat een mooie ontwikkeling is. Ja. Ik denk dat het heel belangrijk is bij het ontwikkelen van die technologie dat er een team samenspraak blijft met kinderen en hun ouders en de behandelaars die betrokken zijn in deze trajecten. En hun de vraag over te stellen, met welke problemen lopen ze aan? Verschillende invalshoeken daarvan te horen. En te zien welke oplossingen dan eigenlijk het beste passen. Ook door zoals dat van opstaan doen. Dat iedereen betrokken is, zodat je goed kan kijken wat zijn mogelijkheden, maar ook wat zijn die beperkingen. En ik denk gewoon dat we veel van elkaar kunnen leren door die ervaringen met elkaar te delen.
Nou, dankjewel voor je gesprek en jouw kijk op het Motion project.
Next, last movie from Copilab and Belgium about the use, I think, of the parkour system.
Ik ben Rune en ik ben Nico. Wat van je? That's it.
Reaction to the last movie? No? Good further.
Just beautiful photos, I think.
So we can. So if there's no reaction, no question, we can have the last presentation of this session with Léa Quentin. Go back to the market. Microphone here. There's only one microphone here. Sorry. Okay.
Let's go. Okay. So good morning, everyone. This morning, my name is Léa Quentin. I'm a lead analyst at Unity Insight. So we are the partner number 6, so Cancer Sussex Academic Health Science Network. And since the start of the project, our department has transitioned into a different organization called Unity Insights. And we'll be talking this morning around the roadmap from innovation to market and what's next for the project. So we'll go over the deliverables, some of the activity conducted, and then looked at updated recommendation from the roadmap report, which was produced in 2020 with some of the latest advancement of the project. So we were involved in the work package number 3, so looking at the roadmap for market transfer. So the first part was the identification of relevant stakeholders, and then the other part was around the roadmap from innovation to market, with as well as some stakeholder involvement activity as part of the project. Great. So if we look at that first activity, so what we did was to do some desktop research to identify relevant stakeholders for motion, and then classify them by different characteristics. So the first one was around the type of stakeholders, so looking at healthcare professional, but also academics, looking at potential users, and finally accelerators and regulatory bodies. And then we also looked at, for each stakeholder, what would be their motivation to engage. So whether that would be around networking, partnership opportunity, looking at economic growth, or knowledge sharing, transfer of technology. And then depending on their motivation to engage, we also assess what the best engagement offer could be. So anything ranging from getting in contact with them to formal collaboration. And so based on that information and then the stakeholder database that we had produced, we developed the dashboards for the Motion project. So looking at an interactive map created on Tableau, which just enabled the consortium to look at different partners, identify what their role and expertise is, and how they could engage with them. And as you can see, as you can see, we also looked at the different countries and then looked at what the relevance would be for the project, as well as what the potential interest could be depending on the size and the characteristics and how closely they were related to the project. So another activity that we were involved with was the sort of general communication and dissemination of some of the results. So obviously everyone in the project did that through some of the activity that Laurent talked about at the start of the presentation. And with Mobilad, we were part of the ISPO 17 Work Congress back to Belenix. And then finally, we worked on the roadmap to from innovation to market. So the idea behind this deliverable was to have a comprehensive guide that would describe some of the steps to commercialization. So obviously, this is looking well ahead for the project, but it's really sort of identifying some of the priorities and some of the elements that the partnership might want to start thinking about to create a really impactful project. So as part of this activity, we presented the national specificity across the 2C regions, so thinking about the healthcare system, the different pathways, and how the access was different for assistive technology in general. And the idea is to really have a living document, something that can be progressed with the technical side of things, so that it's also shaped by the consortium priorities. And so in that spirit, what we have done for today is to look at some of the recommendations that we had made and some of the progress, and think a little bit about the legacy of the project and what is next. So one of the key recommendations was around the patient, parents, and the clinicians. So I think that tells really well with the presentation and the videos that we've had this morning. As we've seen in the survey and the result presented, what the project was able to do was to add to the body of evidence on attitude of the public toward health exoskeleton, and really kind of document the enthusiasm and sometimes some of the resistance. So that's something that will have to be considered further in development. So I think keeping that strong sort of user, patient, parents, and healthcare professional perspective will be key, and also continue to support and the training needs of healthcare professional. Another key recommendation that I think is key to take forward is around the co-design approach. So really being able to have patient-centric design and really use the expertise of the parents, of the healthcare professional who knows what the challenges are to create something that will be impactful. And then finally, another recommendation in that topic is around just the pressure on the workforce in general in the different healthcare system, and just to think about how that might be impacted by the motion output. So whether that's something that can alleviate the pressure or that can assist them in some of the duties, or and how that fits within the workload in general. Another key domain for recommendation was the viability of healthcare system and care pathways. So was this grand strength in working across 4 countries. We do have to consider carefully how the output of the project could be integrated in the different countries. So a couple of questions in terms of what would be the setting. I think we've seen different use cases in terms of how that could be used. What adjustment will have to be done to current pathways. So how much does the current therapy has to change to incorporate the output will be key as well to the product actually being used and making an impact. And then also thinking about maybe different healthcare professionals in different countries will be using it. And if that's the case, how much support they will need depending on the knowledge, depending on the access to the technology that they have, whether do they work in community, in hospital. So now if we're looking at another key recommendation around the route to market procurement. So as I said, I think we are still in a prototyping phase, a testing phase. So I think it's just some of the next question that we might want to think about as a consortium will be around the spread and how that can be developed further. Also the users. So I think that there's been discussion around the type of motricity issues that the children have, and whether the output can be applied to all children, or whether that will be restricted to people that are or children that are already a little bit less impacted by disability. So that's something that will be really important. in terms of how it can be continued, thinking about how it fits into the different commissioning requirements. Does that change depending on the healthcare system? As a partnership, thinking about the different outputs and how they can be, who owns them, how can they be developed further, how can they be shared, and also thinking about maybe some of the output will be progressed to market faster, and some will take longer in development, and I think that's fine as well. It's just assessing the different routes that can be taken forward. So another key recommendation was around the technology readiness and maturity. So a key aim of the consortium was to reach TRL 5 in terms of that laboratory validation. So some of the next milestones that will have to be considered are around testing on the bigger sample size of children, setting clinical trial, and also thinking about real life condition testing after that. And then another element that we wanted to in the mix was the commercial readiness index. So thinking about maybe a different scale of technological development, but also thinking about how the project can be put to market, and especially some of the step around the regulatory certification. Those processes can be very lengthy. So although the project is still in that development and testing phase, having an idea of what you need in terms of safety, accuracy, clinical assurance, it might be a good time to start thinking about that. So similarly, looking at some of the external factors that can impact the project, the next element that was used in the report was a personal analysis. And so looking at political, economical, social, technological, legal, and environmental factors. So I think some of them the project really has lived through in terms of the Brexit and the COVID pandemic, but thinking about the enduring impact, for example, of COVID on the healthcare system, whether there is pressure on healthcare professional, or just how some of the habits have changed in terms of parents and how they engage with healthcare system is also important. And then in terms of maybe some more left field ones, so although environmental impact is in the heart of this project, there's a big push in a number of healthcare systems to have an idea of what the environmental impact of new product will be. So thinking about how the output will contribute to that might be relevant. So we've asked a lot of questions, which is great. But I guess maybe some of the key recommendations that we want to take forward as a group in terms of what is next and how to best use the good work that has been done by the consortium. So I think it's great to hear that there's a next project that will take some of the development further in terms of completing the testing, having a bigger sample size of testing, and then also creating a minimum viable product that will also have the opportunity to raise awareness around the project, give more demonstration, give more visibility to the work, have an ability to share some of the learned elements of the project. So there's been a lot of obviously time spent building relationship between partners and ways of working. So finding a way to share that further will be great as well. Agreements around ownership, IP, and value will also be key, with an aim to also test the project in real life and to be able to evaluate the impact and validate some of the assumptions that we've seen in terms of the best use to further refine the product and finally create a product that can be commercialized. Thank you. And do you have any questions? I think I would say probably to look at the regulatory requirements for that type of product, and especially if it's a medical device, those are really lengthy process. So it might be a good time to, especially if there's elements of the design that will need to be shaped, but what sort of evidence you need to produce. having that embedded in the design, I think will save a lot of time.
So the session is finished. So maybe we can have a short break. And after the break, we will see the technological part of motion project.